Carboxyhemoglobin pulse oximetry in carbon monoxide poisoning. Carbon monoxide pulse oximetry, or SpCO, is a non-invasive technique designed to rapidly estimate carboxyhemoglobin, or COHb, levels in patients suspected of acute carbon monoxide poisoning. This method offers a quick assessment, which is one of its primary advantages. Diagnostic accuracy and limitations. While rapid and non-invasive, the diagnostic accuracy of SpCO is considered suboptimal for clinical screening or definitive diagnosis. A systematic review and meta-analysis involving 6 studies and 1,734 patients assessed its performance using a COHb cutoff of 10%. The pooled sensitivity was found to be 65% and the specificity was 93%. The 65% sensitivity indicates a considerable false negative rate, suggesting that approximately 35% of carbon monoxide poisoning cases could be missed if clinicians rely solely on SpCO readings. Conversely, the high specificity of 93% means that a positive SpCO reading is fairly reliable, yielding a high positive likelihood ratio of 9.4. This high specificity may assist in identifying true cases. However, due to its limited sensitivity, SpCO pulse oximetry is not recommended for screening or excluding carbon monoxide poisoning in emergency department settings. Clinical implications and use. Blood COHb analysis using CO-oximetry remains the diagnostic gold standard for accurate carbon monoxide poisoning diagnosis. Clinicians must exercise caution when ruling out carbon monoxide poisoning based on normal SpCO readings, given the significant risk of false negatives. SpCO results should always be interpreted in conjunction with the patient's clinical suspicion, history, and presenting symptoms. Confirmatory blood COHb measurement is essential for definitive diagnosis and subsequent management decisions. SpCO's rapid and non-invasive nature suggests a potential role in the pre-hospital setting. It may aid in quickly identifying and triaging patients suspected of carbon monoxide poisoning, facilitating timely transport to specialized centers. However, this pre-hospital application requires further validation through larger prospective studies. In summary, pulse CO oximetry possesses moderate specificity but insufficient sensitivity for acute carbon monoxide poisoning diagnosis, thus limiting its clinical utility as a standalone screening tool. Blood COHb testing remains the cornerstone for confirmation.